AI has the potential to transform primary healthcare, disease surveillance and outbreak response, especially in underserved areas. But I think it's clear that we need to ensure that the data driving these innovations are of high quality, are equitable, avoiding bias that could exacerbate health disparities. So today's discussions, we're going to focus on the opportunities that AI presents, but also the challenges we need to overcome and the essential regulatory frameworks needed to ensure safe and effective deployment. So to kick off today, I'm delighted to invite to the stage Anne Stake, Chief Strategy and Product Officer at Medtronic Labs, to share her insights on setting the scene for our discussions. Anne, first of all, thank you for your partnership, for co-hosting this event, and to Medtronic Labs for your support in supporting our journalism here at WHA 77. So perhaps you could briefly help us set the scene here when it comes to integrating AI into last mile health delivery.
Great. Thank you so much, Richard. And wow, thanks everyone for joining. I didn't realize it was going to be standing room only, but I guess AI is such a hot topic. So as Richard was saying, I represent an organization called Medtronic Labs. For those of you who don't know us, we're a nonprofit that works with ministries of health across the world to improve health outcomes and lower cost. We are the steward of an open source platform called Spice, which is designed for integrated primary care, both at the community and the facility level. And since we're part of building the next generation of digital health tools, of course, we're very interested in how AI will transform healthcare delivery at the last mile, both now, today, but also in the future. And we've already seen AI's potential in our own work. For example, we're using machine learning models, and now we can predict patient engagement, and through behavioral interventions have been able to reduce loss to follow-up, which of course leads to better health outcomes. And with partners like the Gates Foundation and Patrick McGovern Foundation, we're also experimenting with large language models. And we believe through some early learnings that the impact could be transformational. But of course, we're still very early, and these AI models keep getting better and better and better. And we're at the beginning of a potential seismic shift, both in healthcare, but also in all other sectors. And I think if we've been keeping up with the news, we know that this could all go very, very badly. But if designed thoughtfully and with stakeholders like community health workers, with patients and communities themselves, we think that AI could be a powerful force in both delivering better population health outcomes and lowering cost and improving efficiency at the last mile. Just as a quick example, we think that if health workers equipped with thoughtfully designed AI tools, we think that they could extend and expand their area of expertise and scope and actually deliver better quality healthcare for a lower cost. But at this point, there's so many questions around AI that we have to figure out. Like, what are the right use cases? Importantly, when are we not supposed to use AI? How do we design a regulatory system that incentivizes investment and innovation, but also protects well-being and human rights? These are just a few. And today, we want to invite some very exciting experts to the stage to actually help us answer some of these questions and include different diverse perspectives. So without any further ado, let's get going.
But thanks for helping us to set the scene, and I think you've done a great job of unpacking that. To further unpack these issues as we take a look into AI delivery for last mile health, I'd like to welcome to the stage my colleague Catherine Cheney, Senior Editor at Devex, and our first guest, Vivek Natarajan, Research Lead at Google Health AI, for a conversation on transforming primary care and community health through AI. So Catherine, over to you, and many thanks.
Thank you, Richard and Anne. And Vivek, thank you so much for taking the time to join us. Yeah, it's a real pleasure to be over here.
So you and I were discussing earlier that you have been on a long journey that continues now at Google to bring some of the benefits of technology to the last mile. And most recently, the way you've been doing this is working on large language models at Google Health AI. Models designed for the medical domain. So I wonder if you can expand on some of that work and where you are in terms of working in-house, developing those models, and actually seeing the impact. And I know your main message here is you need to tread carefully. So can you talk about that?
Yeah, sure, absolutely. So maybe to set a little bit of context and like why I am personally doing this work. I grew up in India, and when I was there, like in parts of the country that I was growing up in, for many people, going to see a doctor was often not an option. So it often meant like walking 30, 40 miles in extreme heat, or giving up on a day's wages, or going without food. And so I knew people who had not seen a doctor in their entire lifetimes. And so this is one of those root node problems that kind of bothered me, and I've always wanted to work on this. And so even a decade back when I was doing my undergrad, a few friends and I, we were putting together this app called Ask the Doctor Anytime, Anywhere. And so the name is kind of like very, very descriptive and kind of tells you what we were trying to do. But back then, the technology and the machine learning and AI necessary for such a system to work was just not ready. So back then, imagine what people did not have feature phones, let alone like the smartphones of today, and there was like no internet connectivity. But if you fast forward a decade right now and look at the arc of progress in technology, everyone has smartphones consuming regularly like gigabits of data, video data, and things like that. And then particularly on the AI and ML front, if you look at the progress with LLMs, and I think everyone has heard about ChatGPT. I hope some of you have also used Gemini, which I think is really good. I hope more of you use it. But with these models, what we actually have are general purpose intelligence substrates. So they're like a very smart friend of yours, like an IQ 150 friend of yours that you can talk to about physics and poetry and philosophy and politics. But if you have a medical concern, or if you require medical advice, do you go to that smart friend? I hope the answer is no to that. I hope you go to a doctor, someone who's really licensed to practice medicine, and understands the nuances and things like that, right? So if you were to use AI in care delivery settings, why should it be any different? We need models that have been trained on high quality medical data. We need models that have undergone rigorous verification and validation. And we need models that are aligned to the values and the practice of medicine. And so this is what we have been doing precisely in our team at Google over the last several years. It's not anything new. It predates the language model era. It predates transformers. And we've deployed many of them. And so we understand what it takes to deploy AI and technology in a responsible manner. And so that's what now we're building on top of, and especially with all the work that has been done before by many of my colleagues at Google. I think we now have this platform and base to really take the next generation of these technologies and now in a responsible manner, but in a sure manner, bring it out in the real world and really have a lot of impact. And so that's kind of the goal, like have world-class medical expertise in the pocket of billions, everyone.
Yeah, it's amazing how your vision for Ask a Doctor Anytime, Anywhere, seemed like a far-off dream, but now, things have really advanced to the point where this could be possible. I just wanted to pick up on something you said. You said you have deployed some of these tools, and you have some learnings on what it looks like to do so responsibly. So can you just share a little bit more about that?
Yeah. So a lot of our deployments are with the previous generation of AI systems, which were supervised in nature. So a lot of our deployments have been with our previous generation of AI systems that are supervised in nature. And so these include our AI systems for detecting eye diseases from fundus images, or detecting pathological conditions from radiology images. And so we worked with, for example, partners such as Apollo and Arvind Eye Hospitals in India, and we've deployed them in clinics, and it's now serving real patients. And so the models back then were far more constrained in terms of the outputs that they were able to provide. And so it was easier to verify and validate them. But it was still a new paradigm back then. And so we had to do that in like a proper manner, in a responsible manner, and then take it out in the real world. And today, I think those systems are really helpful and beneficial, and a lot of people are using them. The same holds true with LLMs as well. With generative AI, they are far more powerful. But that means like on the one hand, it's exciting in terms of the number of things that they can do and the number of potential applications that they enable. But on the other side, the flip side is that like evaluating them and verifying and validating them, dealing with things like hallucinations, which are still a challenge, is also, I think, it's more difficult. So it's important to do it the right way. But I think we know what we're doing.
So you started to touch on this, but one of the keys to large language models work is diverse and representative data sets, which can be particularly challenging in some of the low resource settings that I know a lot of this audience is deeply committed to, making sure these tools are having the positive impacts they could have. But those impacts could very quickly become negative if there aren't diverse and representative data sets. So how are you and how is your team at Google Health AI ensuring that these data sets are diverse and representative?
Yeah. So the work that we do in medical AI, interdisciplinary endeavor. And so we work, it's not just like engineers and researchers, but also like clinical experts and people who have a lot of background in like developing for low resource environments. And so every time we kick off a new project or we think it has the potential to have impact in such settings, we make sure that we take in their inputs. And so they bring in the perspective of what kind of data that you need, what sort of evaluations that you need, what is the local context that you need to deal with. And so inherently, because this is an interdisciplinary endeavor and the way we approach the problem and the way we approach the space, I think that makes it easier for us. But maybe from a technological perspective, one thing I would say is that we tend to bash the internet a lot, right? But the internet is perhaps the richest source of unbiased information in the world in many ways. Like inherently, when people talk about, oh, data is biased, and the solution that they will give you is, oh, use a smaller data set. But a smaller data set is inherently more biased than something that has representative content from everyone. I mean, the proportions may vary, right? But the likelihood of like finding a patient with a similar symptom as you on like the internet is much, much more higher than say on some data set collected at a small medical center. And so sometimes we don't give enough credit to the internet. There's like so many anecdotes and so many rich information that's available. And so when you pre-train your models on that scale of data, I think we underestimate the amount of information that is already encoded over there. That information, no human can contemplate what that means to have that much knowledge. And so that's a good base to start on. I'm not saying that's perfect, but that's a good base to start on. But I think that the biggest lever that we have right now today is actually because of the advancements in generative AI itself, we can actually train these systems in simulation, right? And so one thing that we do when we are training our LLMs particularly for diagnostic use cases, we build up these simulated learning environments. And these environments are not too different from what was used to, for example, train AlphaGo, which was the system that beat Lee Sedol, who was the Go champion back in the day in 2016. But now in these environments, what you can have is you can have like a model playing the doctor, interacting with a patient, and this patient might have a wide variety of like disease presentations, symptoms, medication history, travel history, and also other things that you can moderate over here, like personality, right? And so by interacting with these patients in simulation, these models gain a lot of experience. And so my colleague, Alan, with whom I do a lot of this work, he likes to say that, I mean, if you have the choice between two doctors, go to the one with more gray hair. And so what we are in many ways trying to do with all these simulation environments is we are building the world's most experienced diagnostician. And again, like the number of cases that we can simulate over here, patients with different backgrounds, it's far more than any human can see. And so I think if we just continue on this trend and arc of progress, we are going to naturally have superhuman diagnosticians that are going to really help scale up world-class healthcare to everyone. And so that's the arc and trend over here. And I think the tools and technologies that we have will lead to solutions that are unbiased and really just amplify doctor superpowers.
I did want to narrow in, though, on algorithmic bias specifically. And my understanding is even in a simulated environment, you can only draw on the data you have. And a challenge in many of these markets is either data is not digitized, right? It lives on paper, or there are, people have privacy concerns and they don't want to share their data. And without data, there's a risk of algorithmic bias. And when we talk about how, kind of in the theme of this conversation, AI can help to advance health equity instead of widening existing gaps, you have to deal with algorithmic bias for that to be a reality. So how are you doing that in these settings?
again, I feel like the theme of this conversation is that AI is going to help with everything. And so even things like digitization, like AI, like OCR systems are going to help you do that much better than any previous generation of technologies that you have. They can rapidly look at handwritten prescriptions. And I can promise you, doctors in India don't write well. It's very, very hard for humans to detect that, but AI can do that much, much better than anyone. And so we have these systems. And so the more we deploy them at scale, the more we are able to digitize, the more we are able to get digital data online. We're underestimating how technology is percolating in different parts of the world. And so I think in like a few years' time, we won't be having these sort of conversations. The question, we are going to be all like data rich and data abundant, right? And so the question will be how are we going to be effectively making use of these data sets and the data that's going to come online, and really use that to help people in safe and beneficial manners. And so I think it's like in some ways just a reflection of where we are in time. But I think just looking at the trends of technology, data digitization, and AI, I don't think that's going to be a thing or a challenge that we are going to be talking about in 6 months or maybe beyond.
So I want to get a sense of where we are now and where we're headed. So you mentioned growing up in India and starting to see the potential of how technology could advance healthcare, and that's becoming the case more and more so, right? Your vision for what ask a doctor anytime, anywhere could be is starting to happen. So can you just give us a couple examples of what this really looks like when we talk about in primary care and community health settings? What are we already seeing in terms of impacts? And then where are we headed, say 5 to 10 years from now, as rapidly as things are evolving? How could AI transform the picture 5 to 10 years from now?
Yeah. So I think right now what we are seeing is with LLMs, again, there's a whole range of use cases. And a lot of the use cases right now that people are really deploying in are focused on some of the administrative burden of like our clinicians and our care providers. And to be honest, that takes up a lot of their time. And I think that's a good thing to be doing. And so the more we can free up our clinicians to do what they really want to be doing at the end of the day, which is to provide care and interact with humans, the better it is. And so we are seeing already trends of that where we are doing simple things that are making their lives easier. For example, at Google, we work with HCA Healthcare. And one of the things that they do is like when you are doing a handoff from one nurse to another, there's a bunch of data that needs to be exchanged. And sometimes a lot of information is missed over there. But AI can help like document that properly and do the handoff properly, and that in turn can sometimes lead to meaningful improvements in the quality of care that is delivered, because these are often like really high risk settings. And so there are like simple things that you can do today right now, like scribing the encounters and conversations, putting detailed documentation in your health records, and similar things you can imagine even like low resource environments as well. So that's where I see a lot of the immediate work happening in the next couple of years, where a lot of the things will be not focused so much on the act of like diagnosing and like providing treatment management, but everything else that's come in and crept in, right? Like the administrative stuff. But in the long run, I do believe that the trend is very clear that we are going to be having AI systems that are going to be really good at diagnosing and providing care and treatment management options and things like that. And so the real question is like, how do we bring that technology in? And at the same time, we're not trying to like replace doctors or nurses, but really trying to give them like superpowers. And so my hope and dream, and this is something that I share with a lot of people, my coworkers at Google and colleagues at Google, is like I'm very privileged. I live in Palo Alto, California, and I have access to the best doctors, some of the best specialists in the world. But by nature, they're like very, very rare. Like you're not going to have like another super specialized genetic cardiologist. Like, but how do I make their expertise available to people in India and Africa? Like, and how do we like enable clinicians who are today like taking care of 100 clinicians? How can we make them take care of like 10,000 clinicians maybe, and like scalably allow them to oversee AI systems and scale up their expertise? And so that's kind of the goal. And the more we are able to do that, the more and more we can go towards this vision of having world-class medical expertise in the pocket of billions worldwide. So
absolutely. And access to that world-class medical expertise is particularly needed in countries where you might have one specialist doctor for the entire country. So we have just a little bit of time left. And I just wonder if you can think about people in this room. There are technical experts, but there are also others. Donors, government representatives, leaders from NGOs. So there's what you at Google Health AI can do. But there are others needed to realize this vision and to ensure that these benefits get to these markets, right? That everyone can benefit. So any thoughts on kind of as you think about the next frontier and what's possible, what others can do and what you hope to see?
So the first thing is like, don't be scared of AI. I think if done the right way, it can have a lot of impact. Like there's clearly a lot of safe and beneficial use cases that are coming online. I think it's good to be a skeptic, but in a healthy manner, and being an optimist, but like being restrained and cautious about it. And so not everything that you read on like social media or otherwise is going to be true. And so it's important to like talk to the right set of people who clearly understand where the technology is headed. And then the second thing is, again, like it takes a community. I mean, there's an era of like transformational change over here, and like just a bunch of researchers or ML engineers sitting in Silicon Valley, California, are not going to be able to bring out this societal transformation. So it needs all of us to believe in this and come together in this journey together and like contribute in our own ways with our own unique skill sets. And so I think the more we are able to do that, the more and sooner we can realize the beautiful future that is possible over here. So.
Great way to end. Vivek, thank you so much for joining us. Appreciate it.
Thanks so much for having me.
So I want to go ahead and invite our panelists up to continue this conversation and build on some of what Vivek and I discussed. I'll go ahead and welcome them to the stage. If you want to go ahead and make your way up. Thank you. Give you all a second to get up here and move on down this way. So seated just next to me, we have Samir Pujari, who's the lead for AI and Digital Frontiers in the Department of Digital Health and Innovations here at the World Health Organization. Seated next to him is Rachel Adams. She's the principal investigator of the Global Index on Responsible AI and principal researcher at Research ICT Africa. Oh, is that wrong? Tell us more. Sorry.
No. We've just started a new organization called the Global Center on AI Governance. So that's my affiliation now.
Okay, we're going to hear a little bit more about that in particular. Sorry about that. Seated next to her is Lori Werner, who's the director of the Center of Digital and Data Excellence at PATH. Thanks, Lori. And seated next to her is Annie Hartley, who's the assistant professor at the Laboratory for Intelligent Global Health Technologies, or LIGHT, at Yale University. So first, I want to hear from you about some of the things that excite you, some examples of use cases, and then move into some of the risks and how we can ensure that we maximize the benefits and minimize the risks of these technologies. So, Samir, I wonder if you can take us through how WHO is working to ensure that AI-driven health solutions are implemented ethically and equitably. First, start with what are some of the use cases that excite you, and then how do you think about ethics in the distribution of those technologies?
Thank you so much, Catherine. Very pleasure to be here and amongst this elated panel here as well. Great to hear from Google as well that don't be scared of AI. 2018 was my first interview with Devex, Richard during the AI for Good Summit, when WHO started looking at AI. And I asked in that room at that time when we were doing the AI for Good Summit, how many people, it was similar kind of feeling, a lot of people in the room, but most of them were scared of AI. There was pessimism about AI, that this is it, we are about to be extinguished with this new technology. Today that has changed, and I think there is a lot of optimism in the room around AI. So I think that is already building in. But WHO as core, the main thing that we want to look at is make sure that cautious optimism is applied and that AI is science driven. I think that's where we come from. That's where our leadership has always been wanting to look at WHO's role and enabling our member states to look at how AI can be instilled into the health systems in the rightful manner. Now, when we look at AI, I think it's a huge term, and health systems is a huge term. We cannot generalize. There are some areas where I think AI can make a very rapid impact. And let me give an example. Cervical cancer screening, as a use case you asked me, right, has been a massive problem in rural Africa, one of the most fatal form of cancers which can be treated if diagnosed early, costs several $700 for screen and treat because it's very expensive. And women have to come to different centers and get it done. Now, AI, we have seen use cases where these algorithms can do the first triage and reduce those several hundred costs to a few dollars. That's the impactful AI that we're looking at from a public health perspective. Right? We're not talking of doing robotic surgery from day one. I mean, that's not what our intention is. How can we look at the pain points in health systems? Diabetes is a massive problem. We are not able to diagnose. We don't have health systems to diagnose diabetes. Retinopathy has provided the algorithms that can facilitate that. as of now. I mean, this is the science talking to some extent. So there are these use cases which are big pain points for the health systems, and we want to start looking at building trust through those health pain points. Where can we look at? Because I think in AI, if we don't have trust, it's going to be very difficult to make it institutional across the globe. So I think building that trust through those scientifically validated pain point systems in the health system, where health systems can be enabled, is a big point. Drug discovery. Usually, we've seen the mRNA technology that was changed has made a big difference in the COVID vaccine. How can AI be applied to bring rapid drug discovery in this space? These are use cases which are pain points which cannot be addressed by other interventions at this stage. I think this is where we should have the first intervention niche. As WHO, the first thing that our member states have asked us is, how do we ethically validate these processes? What is the governance mechanism that puts in? So since 2018, working with ITU, and now as of last year with WIPO as well, the World Intellectual Property Organization, WHO has instilled a global initiative on AI for health to make sure that we are not doing verticals all the time. This initiative is to bring together everyone. We spoke with Google, we're speaking with Microsoft, we're speaking with the data authorities. This picture is from the regulatory authorities meeting, where we have all the regulators sitting together and discussing what kind of regulations can be applied for AI. So bringing together everyone at the table is a critical part. We have released guidance on ethics, and these guidance are not just general blah blah. These are specific checklists for governments, for healthcare providers, and for developers as well. We have launched courses around this for developers, for governments, which have checklists, and how do you instill ethics into the programs that you want to use for AI, and how do you sort of validate them as well. That's, I think, what practically has to, we don't want to do the same hoopla around e-health and other systems that we've done in the past. Is yes, it should be done for 20 years, but we come after assembly and we don't show the impact. I think it's a call that I'm putting out for everyone here is, how can we actually say that I have done this ethical validation or regulatory validation from one year to the other on AI? I think that's what our approach as WHO is, to build that community awareness, the community gathering, to help use cases specifically get instilled into the AI systems so that we can take AI for health to the people.
So Samir, one of the things you mentioned was governance, and I want to narrow in on that. Rachel, with apologies earlier for misstating your affiliation, but at the Global Center on AI Governance, obviously, this is what you're all about. So Samir also mentioned cervical cancer as one example of an area where AI could have huge potential. We all know governance of these technologies is important. Can you tell us how you're working on that issue? And then if you can possibly give us an example of a use case where, if not governed in a certain way, we could see actually negative impacts instead of positive impacts of this technology.
Yeah, thank you so much. It's wonderful to be here with such great people. So I think, firstly, AI governance is a huge space that covers a number of things. I think with regards to health specifically, we're going to be moving more towards the regulation side. There's a big debate over whether we want to be regulating AI or governing it through policies, framework, or self-regulatory measures. But I think specifically with health, there's a little bit more of a leaning towards we need to regulate this. And this is partly because the health space has been regulated in a more stringent and specific way in the past. So our work is very much focused on the African continent. We are a global center, so we work globally, and that's really because of this project called the Global Index on Responsible AI that's trying to say, well, okay, we've committed to ethical and responsible AI, but what does this look like in practice? And what are countries around the world doing to commit and make progress towards these goals? The index, the findings, the rankings, and the scores will be released on the 13th of June next month. So I don't want to say too much, but it's really, really exciting and interesting. But from a kind of AI governance on the continent space, what we're really, really interested in is understanding how we move from, okay, there's a lot of good use cases and it potentially can have all these benefits in these different ways, to how do we know this is working? How do we see that there is empirical evidence that says, yes, it really is helping to improve health outcomes for everybody and not just certain groups? And then how do we take this evidence to the policymakers that we work with whether at a national or regional level, to help them develop very specific governance and policy responses that deal with the specific contextual content issues that each individual country faces. I think that's been a really important lesson for us, and particularly with the Global Index on Responsible AI, is no matter where you are in the world, every country has its own existing regulatory structures and frameworks that AI governance needs to layer on top of. And so relying on how many countries across Africa have existing data protection laws only helps us go so far. I'll pause there. Thank you.
So I wonder, Samir and Rachel have both mentioned that there are all these potential use cases that are discussed. But Lori, I know one of the things you're focused on at PATH is actually how AI can improve the efficiency of health systems overall. So can you tell us a little bit more about what PATH is doing and what opportunities you see, as well as some of the risks you're working to avoid in terms of AI's potential impact on health systems?
Yeah, and thanks so much for having us. And this is quite the panel to be on. So I think there's a lot, and there's been a lot of conversation this week around the promise and the opportunity of generative AI. And I think we are also excited about that. I can talk a little bit about what we're doing in that space. But one thing, there's a couple things I wanted to highlight that we see as most exciting right now is some of the work that's been going on for a few years and ways that can optimize and create efficiencies in the health system. And especially things that can help reduce the burden on health workers as well as management, et cetera. So the use case I want to highlight is really around supply chain. We did some work 6 years ago with a company called Macrorize. They're now called Pendulum. And in Tanzania, looking at their vaccine supply chain information and their logistic management information system, combining that with population data, meteorological data, to really look at and training their machine learning algorithm to be able to predict stockouts. And so using historical data, they were really able to very accurately predict where stockouts would happen. And this is actually something that saves lives. As vaccine stockouts are reduced by 10%, over 300,000 lives can be saved. So it's a very tangible example of AI technologies that can really make a difference. So that's one that I'm very excited about. So yeah, I think in general, being able to think about the impact, and I can speak a little bit later about some of the evidence generation we're doing too. But yeah.
Sounds great. Yeah, I think the stockouts example is a very interesting one in terms of a use case for AI. Annie, I know that when we talk about low resource settings and the potential of AI in these markets, you've seen that. You've worked in these settings throughout your career, including in the Ebola response, for example, which of course we weren't at this place with technology at that time. But can you take us through how AI can be forecasted even in low resource settings, as well as what are the limits? What are the very real limits to using these technologies at this point?
Yeah, sure. So first of all, I have to apologize for my voice. I'm recovering from laryngitis. I haven't been out on the town last night, making bad decisions or something. But yeah. So I work in the space. I'm a medical doctor, but also a professor of AI, and we really are trying in our lab to make AI tools specifically adapted to low resource settings. And data science, it's not a big stretch to understand that it relies on data. And one of the things that are missing in low resource settings is data. And so you can make any sort of fancy model that you want to. We make all sorts of models. But if you don't have a reliable data stream from people that you can rely on, that's interoperable, that's live streamed, your tool is going to be absolutely useless. You mentioned the Ebola thing. It was a really visceral experience. It completely changed my career. Everyone is kind of used to masks and epidemics now after COVID, but during the Ebola epidemic in 2014, it was a different time. This wasn't a less than 1% mortality. It was a 80 to 90% mortality. No one knew how this was spread. It was a really horrible disease, and it still is. And I was based in Sierra Leone at the time. I still have some dreams about, touching things, and it was visceral. And even with all of that stress behind being exposed to this unknown, people still didn't want to share their data. So what will? the motivation for keeping data private and for keeping data ownership, it's very well founded. It ranges from ethics, of course, and maybe some selfish things like, oh, I want to publish first or whatever. But it also goes all the way to, I'm not sure if I collected this right. What if I share this with the WHO and I'm going to lead them astray because I wasn't thinking, I'm not scientific enough. And we had all of these different reasons for this. And there was all these kumbaya moments afterwards where people were saying, well, let's come together, let's share data, copy, Control-C, Control-V. We put all this data in this nice big server. And I was the first person to get access. I was so proud I was going to be the first person to get access to this data when it was all shared from the Ebola epidemic. And it took 5 years. 5 years. So how can we forecast data? How can we forecast trends or anything? People are not going to share their data. So that's why I got really obsessed with this. We can speak about the other work that we're doing, but something that we're doing quite a lot is making AI tools that make data available for AI. So we have a platform called Disco for distributed collaborative learning. And of course, it's got a slowly rotating disco ball as the logo, which took me an unreasonable amount of time to make. But what it's doing basically, instead of copy pasting your data to the source of the model, you're copying the data. Instead of copying the data to the source of the model, you're copying the model to the source of the data. You're distributing the learning. Distributed learning, federated learning, decentralized learning. You're decentralizing the learning process so that people have this fine-grained control of how they actually use their data, how other people use their data. When you just copy-paste, anyone can. You just go. You can predict this, but please don't predict that. And you've just got to trust the person that you're sharing this with. But if you are accepting models, you can go, well, you are using these inputs and this is the output, and you've got this fine-grained control that's also temporally controlled about how and when you share data and how long you share it for and what data you are sharing. So it's very important to create the tools that are making the data available for the AI models that we're eventually going to make. Yeah.
Really interesting. So Annie mentioned, one of the huge barriers being that people don't want to share their data, and this interesting approach of sort of decentralizing what is typically a more centralized large language model. I want to hear from you, Laura. You started to preview some of your work, but I want to return to you on, beyond stockouts. What are some other ways that Path is working to make these kinds of tools available and effective in these settings? And how are you dealing with the very real challenges Annie mentioned that often people don't want to share their data?
Yeah, it's actually a really, really important point. So I think a couple of things I want to highlight. Ways that one of the key things we're working on is localization. And by localization, I really mean the capacity strengthening of the technical services available in the low and middle income countries in the context we're talking about. So this is really building the capacity and partnering with local digital entrepreneurs in the countries, as well as the universities. We did some work a couple of years ago with the Bear Foundation and Medic Mobile to do a call for software developers in Africa who have small businesses who wanted to really think about how to build sustainable business models and strengthen their capacity to serve the governments. And so this was a process to then really help build those small businesses to be available to governments in the countries, in the regions, where so often they have to rely on international software developers, and they don't have that technical capacity right there with them in their settings to be able to really think about this. And I think as the AI possibility and the models and the technologies grow, this is going to be even more important. So that's one area. And then the other is really thinking about evidence generation. I think this has come up a few times and is so important. We are just now beginning some work that's funded by the Gates Foundation to work with the Grand Challenges recipients who are developing large language models and some local universities in Africa to develop some local data sets to train the large language models and then do some silent trials. So some very, protected trials to really generate that evidence and understand what what is possible and what are we learning? So that's another really important way that we're looking at it. And we're paying, as PATH, we're really play the technical secretariat role. And I think collaboration and partnership is another theme that has come up a lot. And so how can we all come together and be able to learn together and then provide the countries and the ministers of health with the right information at the right time about the technology?
So before we open it up to audience Q&A, I do want to make sure we directly address regulatory frameworks. It's something that was previewed in the opening of this conversation. Rachel, I want to start with you. And, you often hear that regulation can stifle innovation. I understand that argument. And yet we're talking about people's lives. So the stakes are very high. Can you talk about the role of regulatory frameworks in striking this balance, ensuring that AI can see broad benefits, but also ensuring that it's used responsibly?
Yeah, I feel quite strongly about this because I've worked with a number of really interesting innovators across the African continent to try and understand where they've got some kind of really exciting use case. What are the barriers they're facing to try and scale this work so it has a larger impact on their societies? And one of the barriers to innovation is a lack of regulatory frameworks. So without this regulatory pathway, without a government saying what you're doing is legitimate and it's authorized and it's fair and it's safe, innovators can behave conservatively. So actually, we want to be supporting the kind of innovators that want to do their work on the right side of law and they want to do it safely. So I think regulation is really important. I don't think it's a quick fix. I don't think we can kind of quickly put in place regulatory frameworks. Part of the work that I've been doing over the last few years is working with research ethics committees, which is a kind of first line of safeguarding for the design of new AI-related or just any kind of health research. And there's a lot of pushback to take on board new kinds of compliance or new kinds of protocols or requirements. So I think there's a lot of work that we need to do to kind of socialize why regulation is going to be beneficial and is going to help us grow sustainably in the right way.
So one more quick question on regulation before we open it up. Samir, patient data has come up a lot. And I want to know how you see regulation playing a role when it comes specifically to safeguarding patient data.
I think it's not specific to AI. Patient data has and regulation, the safety. We need to isolate the opportunities that we have with AI and the data security and the data privacy issues. Data governance in general has been discussed, has to be structured well and sort of managed that ways. In terms of regulations, I was recently at a meeting with about 70 regulators that were hosted by South Korea to discuss AI governance and AI regulations specifically. Data is one part of it, but I think as Dr. Rachel mentioned, it has to be understood that if you don't have the right regulation in the right time, you are inhibiting the innovation. And we saw that during COVID. Because of the lack of regulations, we could not have contact tracing rapidly deployed, which delayed the opportunity of sort of control. So I think that's why it has to be understood, and that's WHO has released the guidance with these different regulators to start deploying. It has to be thought differently, though. As we are approaching AI is a different ball game. We have to think that regulation cannot be static. It has to be agile. It has to be able to adapt itself rapidly, whether it's patient data, whether it's the usage of the patient's data, how it's been done. I mean, Professor Annie mentioned about the reluctance of getting this data available. I was given an anecdote by CERN that CERN in particle physics, about 90% of the data is available for research. In health, we are close to 20%. I mean, that needs to change itself in general, whether it's AI specific research or in general other research also. I think that will make a difference. AI will benefit massive changes. So this is where the regulators will have to come and play. But again, it's a call for everyone. We can't say it's your job to give the data. It is our job as an implementer, as a user, to try and find a mechanism, a creative way of how this data can be put to good use.
Thanks, Samir. I want to bring in a question from the audience. And I know we have joining us Andrew Cross, who's the Strategic Initiatives Manager for the Stop TB Partnership. So would love to hear any reactions you have or questions for the panelists.
Absolutely. Well, thank you to the organizers for inviting me to open the questions and to all the panelists for your comments. My name is Andrew Cross. I'm from the Stop TB Partnership, and we're very interested in supporting the rollout of new innovations for TB service delivery, which is a lot of it last mile and a lot of it in very challenging environments. So continuing the kind of conversation around ethics, I think there are many in this room and many in our space that would say AI is very exciting. It's a new tool in our tool belt. We should use everything possible in these very, very challenging environments, which are already very resource constrained. Despite the fact that there may be risks, we may not be scared of AI, but we don't quite know what it is. We don't know best practices, but we really need it. I think there's another camp that says we'll get there. We really want to use that, but let's first let these tools mature in more high-income markets or high-resource settings that have better safeguards in place. And I don't just mean global north and global south, but even urban environments versus the last mile. So open to the panel, but how do you view this tension? Where should we be putting our energy? Is there a sequence to these events, or should we be throwing everything we have at everything at once? Thank you.
Thank you. You want to go for it, Annie?
Okay, so yeah, I think with ethical frameworks in general, with all of these tools, we have the ethical responsibility to make sure that that the accuracy and the performance of them are equitably distributed to different places, and to do this transparently. We can't have all of these, like, where it becomes scary is where we've got all these like corporations that have got like closed source models and we have no idea how they work. And then they say, well, we're 99.9% accurate, trust us. Says who? Based on what? On which data? And they go, well, our large language models, and it should be scary to everyone here, that large language models for medicine are mostly tested on a set of 7,000 questions, coming mostly from the US MLE exams. So this is the US licensing exams. It's so biased in terms of geography. It doesn't represent our epidemiology in the settings we're working. It doesn't ask hard questions that we actually need to ask. These adversarial questions about, questions that don't get asked in exams, like how can I bump my patient up the transplant list, or understanding the contextual nuances of where we're working. And lots of times in low resource settings, especially in TB environments, doctors are the last people that the patients are coming to. So we need to understand this and localize the evaluation and do it transparently and openly. And this is the most important thing that we can do in terms of ethics, is opening up the model so that we can actually see how they work and we can probe and scrutinize them. That's why we've made this platform. We make large language models as well for the International Committee for the Red Cross and others. They ask us to make these tools. So we've made some tools. One is called Meditron. But it doesn't really matter. It's about comparing all the tools, having a transparent leaderboard. This is the best model for this one in this place. And so we formalized this in a platform called Move, which is a massive. It has to be massive. We need to hold our models to a higher count. 7,000 questions. Okay. Doctors, we don't get 7,000 questions in our exams. That would take a long time. So we already are holding them to a higher account. We get about 400. But we need to hold them to a higher account because we can. We can ask 1 million questions. And so we this massive platform tries to crowdsource information from all different people. It's open online validation and evaluation. So it's open because we have all the different models and people can openly put them to the test and scrutinize them and ask hard questions. And then the evaluation becomes localized and they own the evaluation. But not only that, they can own the output of the evaluation. So now when they are evaluating and they say, hey, this model is doing badly in this place for this specialty and it's granular, right? We're going beyond just accuracy. It's trust, confidence, it's patient outcomes for once, and we're going beyond that and we're saying, well, we can actually hold these models to account and then take that information about where they're failing and feed it back into the model. And now they are actually owning the models. And so the Move platform, what we do, it's become a verb. We move the model, right? And we move it so that we can make a model for them with their own evaluations openly on a neutral platform. No companies have any stake in it. There's no profit involved. It's people who just want to evaluate tools and make tools for their own settings. And we can do this with everyone's model. So I really hope that, now we just need to make sure that we can have that last column of our evaluation metric of patient outcomes, running trials, which costs money in the short term. But once we've invested in it and we've actually seen how these are, for patient safety and outcomes, once we actually collect that data, we make an asset and we make a set of assets that represent populations better. Yeah.
Thank you. Did anyone else want to jump in? Rachel?
Yeah, I think this is a great question. My experience has been that the hype around what AI can do is making us slightly blind. And I think there is an ethical principle that we're forgetting, which is proportionality. AI should be used where AI can solve a problem that humans can't. So I think a great example is colleagues of mine at the Makerere Institute for Infectious Diseases has been rolling out AI-driven drones to deliver ARVs to people living on Lake Victoria. Great example. But I think where we're saying that we should provide frontline workers with the technology to be able to serve 100,000, 200,000 people, we're not solving the structural problem, which is that we need to train more doctors and train more nurses, not provide people with a technology that's going to gloss over an issue. AI is not the solution, it is part of a suite of solutions, and I think we need to remember that.
Well put. Go ahead, Lori.
Yeah, I'll just add, because you just made me think of an interesting point I've also heard talked about is I think it definitely needs to be tested and really be in the countries and not wait for it to mature in high-income countries. But I think it can also be thinking about how does the business need to change? How can AI really help think about having different structures, but it has to be therefore applied in the setting to really understand what that might look like, if that's even a possibility, and do so in an ethical way.
Thank you. So we have so much interest in this room. I do want to make sure to get to another audience question or two. So if I could have a colleague help with the mic. So many questions, where to begin? Maybe toward the back of the room, since you've been so patient back there. This gentleman straight ahead, could we get him the mic back there? And then I'll take another one as well, just after him. Jess, if next we can go to the woman seated to your left, and we'll grab those two questions, and we'll hear them both in order. Go ahead.
So thank you very much, Catherine. My name is Dr. Charles Kamodo from Kenya. I run a telehealth company called Daktari Africa. We've been running since 2008. I'd just like to echo Dr. Annie's comments earlier on about the need for data from the ground, real data. I think this is really crucial. There's generally a big data divide that occurs between the higher income countries and the lower and middle income countries. And actually, there's an article precisely about that in last week's edition of the New England Journal of Medicine dedicated to AI, talks of the great medical data divide. So I'd really like to encourage all the panelists to really look at working with organizations on the ground so that we can actually furnish you with some of this data. I like what Rachel mentioned about having continuous work with people on the ground, the community health workers, the nurses, because those are the actual people who will collect that data from the patients. Mm-hmm. And to Samir, of course, the WHO is really big on this, and I would like to see more partnerships once again with such organizations on the ground, so that even organizations such as PATH and Annie can also look, or Lori, sorry, to look towards Africa and see how you can perhaps map out all those organizations that have their feet properly on the ground, so that we can furnish you with the real data to come up with the real active AI models. Because I believe, by the way, that AI is the new kid on the block that will really change the way we practice medicine. But for it to be applicable globally, we need data from the continent that will have the most proportion of people by the year 2050, which is Africa. A quarter of the population will be living there. So thank you so much.
Thank you so much. Appreciate it. So we will get to this question of how can we work more closely with organizations on the ground. And one more question, if you could.
Hi, thanks so much. I'm Professor Meg Davis from University of Warwick from the Digital Health and Rights Project. Great discussion. My question is about Google Health AI and how we ensure accountability, given that regulatory frameworks are mostly at the national level. So if there are harms from what is essentially a global experiment without a control group, how do we hold Google accountable? Thank you.
Thank you. Well, two questions for our panel then. One, how can we work more closely with groups on the ground? And two, how can we ensure accountability, including from private sector actors in this space when regulation is happening at a national level? Who wants to jump in? Samir, maybe since you didn't have the chance.
The first question, how do we work together? And this was the precise reason why we created this global initiative, where we don't want to recreate the wheel. Everyone is doing, if there are solutions, if there are good practices, how can we learn from each other, and as well not recreate the wheel every time from one country to the other, especially working in the low-middle income country settings. So the global initiative is an open platform for stakeholders to join in, whether it's a topic-specific area, whether it's a cross-cutting area. Please reach out, and there is a space for everyone to come, bring your expertise as well as learn from the practice there. If you just look up Global Initiative on AI for Health, these are 3 agencies. Whether you have questions around patents, which is why WIPO is involved, whether you have questions around technology, open code initiatives, data sharing is a big piece of the work that we're trying to trigger into this space. We cannot replicate a CERN at this immediate instance, not a Snapchat thing, but there are ways of at least triggering some federal learning and bilateral learning data sharing models, which we are training. So there is a platform and initiative where we have over 500 collaborators already from institutions from all the top world who are collaborating. So I think that's a quick answer to this one. And to really react very quickly, I think regulations to me is the right answer at that point of time, having the right agile regulations, which is missing entirely for the country to decide who's to be held responsible, what is the liability issues. This needs to be understood very rapidly and applied in the countries. But I'm sure
Limited time, but responses to either of those questions, who wants to jump in?
Yeah, I'll just speak to the partnering in the local with local entities, because that is really how we work at PATH. I mean, we have countries we have offices in over 20 countries. And so the work I mentioned earlier that we're just starting with the large language models, I mean, that is with our offices in country, but also with the local universities and with the innovators who are based around the world, but often in those countries. And I think that is, PATH is nearly 50 years old. That's how we've worked on product development, health technologies for decades now, about how we bring together the private sector, the governments, the innovators, as well as then in the policy side. And so that's something that we're applying to this very model. And I think it's absolutely needs to happen that way. And that's really the way that we'll learn about how this is going to be successful.
Thank you. Annie, very quickly, your last word. Go ahead.
Okay. I'll try my best. So just for your question about partnering and getting data, people must remember that you don't just make a model and then just deploy it. A model is part of a data collection system, machine learning. It learns from something. And so to make a model without a data collection system attached to it is a mistake. And it's a real problem that people are facing now, that they're not including it. And for the second question about how we hold companies to account, well, it should just be that we not have to recreate the wheel here. Transparency and open science and open data, neutral spaces need to be made so that companies make very valuable tools that we use and we want to use them, but we need to be able to just have a neutral space where we can put them to the test openly and transparently so that it's outside of the company and perhaps in academia or in other neutral spaces where this can work, such as that's what we're trying to do with the move. Yeah.
Well, collaboration seems to be a big takeaway here. So I hope you'll come find the panelists after this conversation. And with that, I want to thank them, ask them to take their seats as I welcome Richard back to the stage. Thank you.
Thank you, Catherine, and to all our guests. That was a fantastic panel. I think we've just got such a rich seam of conversation to explore further, hopefully in future events on AI and healthcare as well. But thank you to you, our audience, for your interest today. I think that what's clear to me is that AI is a tremendous opportunity to improve diagnosis, treatment, and overall patient outcomes, as we heard from our panel there. But there is also this note of caution to remain vigilant when we're addressing the challenges of data quality, equity, and ethics, which I think all of our panelists discussed today. For a few final words, I'd like to ask Anne Stake from Medtronic Labs to join me on stage. And I'm not sure if you have any reflections or any key takeaways, or maybe you just want to leave our audience with a quick call to action before we wrap.
Yeah, hello? Is this working?
We're on.
Okay.
Live.
Great. On behalf of Medtronic Labs, I just want to thank the panelists and the fireside chat and the fire starter for a wonderful discussion. I thought that was really rich. I don't think we answered all of our questions. I think there's a lot more questions that we have to keep asking. And my main takeaway is that it's critically important for everyone, not just the technologists, to be at the table right? And not just react to what AI is going to do to us, but actually co-create what we want AI to do for us. And that's why my call to action is really to join a collective that we're building. It came out of a lot of conversations here at WHA earlier this week and more that are happening later this week. It's with partners like Path, like partners Google, Yale, pretty much everyone you've heard from today. And we want it to be inclusive and open. So please reach out to me or I think any of the panelists to get more information and to join. I'll link you up with the right people that are hosting this collective to make sure that we're actually building this together. So thank you so much.
Thanks, Anne, and thanks for your partnership. Once again, a big thank you to our co-host Medtronic Labs, to our in-person and online audience. Please stay tuned for day 2 of Devex's checkup at WHA 77 Summit. That's going to be in about an hour's time after a lunch break. And we'll be kicking off that session on the topic of resilient health systems. So yeah, to you, our in-person audience here at the Intercontinental in Geneva, online watching around the world, many thanks indeed, and this conversation will definitely continue on Devex.com.